Hello, my name is Pat Emily Maricito Polomeni. I'll be discussing mental health needs of special populations. We'll be discussing the elderly and geriatric population. 75 million Americans will be over the age of 65 by 2030. 1 in 5 older adults in the U.S. experience mental illness, substance use disorders, or both. 15% suffer from mental disorder, 20% suffer from a mental or neurologic disorder, excluding headache disorders. 5% and 7% suffer from dementia and depression. 3.8% suffer from anxiety disorders. 1% have substance use problems, mostly alcohol related, and 25% will result in suicide. Every encounter with an adult patient would need a dementia screen and a depression screen, alcohol misuse and abuse screening, and a prescription medication misuse. That is a medication reconciliation, which includes over-the-counter and herbal medications. We should integrate the routine screening for medication and alcohol misuse, especially in patients who have multiple comorbidities. This will mean that patients have multiple medications, and some of them may accumulate these medications at home and may be misusing them. It would be good to continue asking the patients what medications they're currently using, comparing the bottles and the date of dispensation, and ask them why they're using it. Also determine if they're using any over-the-counter medications, pain medications, especially opioids, and any herbals, supplements. Provide any intervention and counseling and re-education about these medications and their use, if there are any misuse of medications. This group of population will also experience social isolation and depression. They can be connected with social groups, adult daycares, managed care organizations that can help facilitate socialization and transportation to get them around to keep them active and engaged in the community. Next, we'll be talking about perinatal and lactation population. So this would be females of childbearing age. 15 to 20% of women experience more significant symptoms of depression or anxiety during pregnancy or after the birth of a child. Symptoms may appear during pregnancy and the first 12 months after childbirth. 1 per 100,000 mothers in the USA commit suicide. Incidence of infanticide range from 2 to 7 per 100,000 infants. You can use a screening for depression with a self-reported 10-item Edinburgh postnatal depression scale, or you can use a modification of the PHQ-9, PHQ-2. You can ask a reasonable alternative question like, during the last month, have you often been bothered by feeling down, depressed, or hopeless? Any patients who have a positive in this screening would need to continue to be evaluated with appropriate laboratories to make sure it's not an organic cause, and a referral to mental health and psychiatry for further evaluation and follow-up. Perinatal screening for mood disorder is important for prevention and treatment. Identification as early as possible can be helpful and can prevent a lot of problems later on, especially once the child is born and there is extra stress as the mother goes into a new role. Help identify any support groups that includes family and social support groups, referral to mental health specialists for further evaluation and follow-up. And every encounter should have a suicide prevention counseling and the counseling on access of lethal means, as suicide crisis may be abrupt and may occur quickly. So you have to make sure that that the patient is not suicidal when you see them. Let's talk about the pediatric population. Worldwide, 10 to 20% of children and adolescents experience mental disorders, beginning at the age of 14 and through mid-20s. You can identify, these disorders can be identified as anxiety, depression, oppositional defiance disorder, conduct disorder, attentional deficit hyperactivity disorder, Tourette syndrome, obsessive compulsive disorder, post-traumatic stress disorder. In the pediatric population, developmental disorder, physical disabilities, and chronic medical conditions are included. And these are risks for substance use, self-harm, and suicide. At the primary care level, pediatric patients should have a complete history and physical examination, take into account the social history of the child, the socioeconomic background, the family structure, and their school experience. For example, do they come from an affluent background? Do they come from a single family household? Do they experience bullying at home? So mental, behavioral, and development disorders begin in early childhood. They can be identified in 6 children between the age of 2 to 8 years old. And the rate of mental disorders change with age. So behavioral problems are more common among 6 to 11-year-olds. And the diagnosis of depression and anxiety are more common with the older children into their teens. So the key is to early identification and intervention. So what can be done? Mental health referral can be made for further evaluation to see if any of the alarming behavioral mental changes or abnormalities are consistent with the DSM-5 criteria for mood disorders. You can bring about interdisciplinary involvement to provide evidence-based treatment and prevention at the primary care level with child and adolescent psychiatry and cognitive behavioral therapy. Now let's talk about the LGBT community. This group experienced a lot of barriers and discrimination in the health in receiving appropriate health care. 31% of LGBTQ older adults report depressive symptoms. 39% report serious thoughts of taking their own lives. 40% of transgender adults have attempted suicide in their lifetime. 40% of LGBT adults have experienced rejection from family members or a close friend, and they are at high risk of homelessness. So you have to take a comprehensive medical, social, and psychiatric history, identify any risks, behavioral, socioeconomic status, support groups, traumatic events, any violence in their life, bullying, substance abuse, suicidal ideations, and attempts. You can use the PHQ-9, Audit C, and DSM-5. Understand the sexual practices and possible health risks in this population, and help them navigate through HIV prevention. So the biggest thing we have to discuss is breaking the barrier to access of care, especially at the primary care level. Gender inclusive language must be used, and ask the patient what pronoun they prefer at the first encounter. There's continued education that can be offered at the provider level for comprehensive and cultural competency. If the patient does have any positive symptoms for depression, anxiety, or suicidal ideations, it is very important to refer them out to psychiatric specialists for further evaluation and follow-up. With substance abuse and addiction, an interdisciplinary approach is important, and to help them navigate through support outlets that can help them with substance abuse, addiction, and mental illness. So as a provider, we should advocate for acceptance, love, and support in this population and speak out against discrimination. And this can help break the barrier to access of care for this population. Next, we'll talk about the migrant worker. The immigrant population, according to a 2015 survey, identifies there at 43.3 million, or 13.5% of the total U.S. population are immigrant populations. This group of people have a lot of fears, especially in the current administration, with shifting immigration policies. There's a lot of tension and in the undocumented immigration group, who are high risk of being uninsured because they have limited access to coverage options. They're also facing barriers to accessing care due to their high uninsured rates. And when they do have access to care, it is at a low-cost care facility through community health centers, which are often limited to preventive and primary care. So they will have challenges in accessing specialties like mental health and substance abuse care. So when you encounter a patient at the primary care level, you want to take a comprehensive medical, social, and psychiatric history, identify any behavioral, socioeconomic status, support groups, traumatic events, any violence or bullying, substance abuse, suicidal ideations, and suicide attempts. Different groups will experience different stresses. Documented immigrants will feel the trauma of leaving their country of origin and experience the stress of acculturation and these things on how they impact the family. Undocumented immigrants experience chronic and severe distress, decreased self-esteem, helplessness, and hypervigilance. U.S.-born children of undocumented parents will continue to experience the anxiety, fear, and depression of being potentially separated from their parents due to deportation. And the deferred action for child arrivals, these recipients feel the increased responsibility and the burden and the loss of their DACA status, resulting in increased anxiety and fear. So the biggest challenge to prevention and treatment is access to care. There are discussions in the eligibility restrictions and attempting to expand the coverage for undocumented immigrants. However, it's a little controversial or very difficult to determine who will be covering the cost and who will be sharing the cost. So thank you so much for taking the time to listen to my presentation. You can take a look at my references. And I hope that you learned a little bit from my presentation. Thank you so much and have a good evening. Bye-bye.